Okay, we're going to start then. And so again, good morning, good afternoon, and good evening. Thank you for joining this session on the Global Fund Grant Cycle 8 Strategic Shifts. I'm Marcela from the Communications Department, and I would like to just give you a few housekeeping topics. One is, if you can please select the language in which you want to listen to this session. Yes, you can click the interpretation button and select English if you're listening to English. For the rest of the languages, cliquez s'il vous plaît sur le bouton interprétation. Haga clic en el botón interpretación, por favor, y elijan español. Clique no botão interpretação e selecione o idioma português. After that, we ask you to please write your questions in the Q&A section here in Zoom. You will see the Q&A at the bottom of the screen. We will respond to questions at the end of the session. Please note that for the moment, the chat is disabled. We can enable it later, but we ask you to please post your questions in the Q&A so that we can respond them at the end of the session. The recording and the presentation will be shared with participants at the end of the session. And with that, let me introduce you to Julia Martin, who's our Head of Strategy and Policy at the Global Fund, and she will lead this session. And thank you everyone again for coming.
Great, thank you very much, Marcela. And good afternoon, good morning, good evening. I think we probably span many time zones. I'm pleased to be with you and pleased to be speaking, but on behalf of many people at the Secretariat that have been involved in developing a package of what we hope are helpful approaches and things to consider as you move into planning for Grant Cycle 8. And so for the agenda today, we'll go through some of the what we call strategic shifts, which we hope that many of you have heard about in detail or at least at some level. And we'll move through each of those shifts, and then we'll open the floor for Q&A, get your feedback, hopefully be able to respond to some of your immediate questions that you might have and hear your comments. Next slide, please. So the Grant Cycle 8 is different. It is different because our context is very different. Those that are leading the charge on offering services and planning for national programs and subnational programs across the diseases and working on health systems will know that 2025 was a very challenging year. There are many things that are impacting the ability for countries to respond to their people's health needs, and both with insecurity, civil insecurity, but also financial. And so on the financial piece, we've seen some very significant changes in donor-led financing. And we're working to, with those changes, to make, and we believe, Grant Cycle 8 a very viable and an important part of the trajectory of national disease programs and resilient systems for health. So with this very changing health landscape and a very positive, good, strong voice around country self-reliance, around health outcomes, the Global Fund Secretariat has worked and the partnership has worked to respond to that. And Grant Cycle 8 is really all about sustainable program design and effective transitions. We'll work through that a bit systematically, but I'd like you to hold on to those two thoughts: sustainable program design and effective transitions. They're not new words. They're not new words to anyone, but how they will be framed should and is different. You will have received the allocation letters successfully started to go out last Friday, and I believe are fully completed. And in that, there are some very specific aims that have been laid out and discussion of the strategic shifts to try and jumpstart the in-country discussions. Next, please. So what are the shifts and how do they support a path for country self-reliance in all ways. These are the shifts with sustainable program and design and effective transitions as the black and yellow circles as the center. The first is supporting effective and predictable transitions from global fund financing. I'll go into each of these in some detail. The second is all about prioritization, the global fund investments and prioritizing those investments and how funds are used. The third is integration, systems integration, delivery integration, the three disease integration amongst the three diseases within primary healthcare in support of universal healthcare. The fourth is community health systems and sustainable financing. We know collectively that community is an incredibly important part of how health is delivered and sustained over time. And then lastly, how to optimize the domestic resources available and effective co-financing, an incredibly important part of how programs in countries are sustained over time in the long duration, as well as making sure that transitions really can and should be effective. Next, please. So the first one to spend just a little bit of time on is the predictable, and that word is important, transitioning from global fund financing. Next, please. So something that is considerably different than in GC8 and GC9 transition timelines for some countries and some components within countries have been laid out. For 63 components, those are disease components, which span 35 countries and 3 multi-country grants or recipients, the GC8 will be the final allocation of funding support from the Global Fund. This means that countries have a minimum of 4, but in most cases 5 years to plan for that eventual transition. Likewise, in GC9, there will be an additional 21 disease components across 12 countries that will see GC9 as their final allocation. And those countries correspondingly will have up to 7 years, a minimum of 7, not up to, a minimum of 7 years to plan for those transitions. The predictability and transparency of what has been laid out in the allocation letters for those countries that are in either of these two categories has been an important discussion within the Global Fund Partnership. It's not appropriate to give 1 or 2 years notice about transitioning off of financing. It is important to show that predictability, to be able to effectively work with a known timeline so that things that need to be prioritized by a country can be prioritized. We hope that the partnership sees this as both a respect for the partnership that we have and wanting to ensure that the Global Fund Secretariat, the technical partners, walk with those countries in this journey ahead. Next, please. So the Global Fund support for transition, how are we looking to do this? One is that it's important to look at different stages and steps in the process of the big process of the Global Fund. The first is the funding request development and grant design. We've looked at how to leverage grant financing and support investment pathways towards transition. There's just been an enormous amount of work that has gone in to thinking carefully about each individual country, the context, their situation, their disease progress, the outcomes achieved to date, and what might be necessary and important for the country to consider during the next 4 to 5 years or 7 years and beyond. So looking at how to align and transfer of core program costs to national budgets is obviously an incredibly important one for the discussion in the grant design and the funding request. Also looking at the most critical barriers that would not allow for a successful transition. And successful transition would mean that services continue without a break and at quality. The second piece of work that is very intentional in GC8 is the co-financing commitments. These have been differentiated across the portfolio, meaning at a country by country level, having a very differentiated approach to co-financing, which is mapped to the country's both capacity and where they're at, looking at the programmatic commitments and the financial commitments together. And then the third thing is just overall country engagement. The Global Fund is committed to leveraging the country dialogue, the funding request development, all pieces of grant development that can be used as entry points for discussion and really good planning around how to create the environment for a successful transition. Next, please. So I'm going to move on to using an adjective, rigorous prioritization of Global Fund investments. The rigorous is important. Prioritization is difficult. Bringing rigor to that prioritization conversation is what is going to be incredibly important as countries move into their discussions about how to use resources which are lower across the board, to make sure that they are financing and able to finance the most critical parts of their investment portfolio. Next, please. And so what does this mean in practice? So evidence-based interventions, a word we're all very comfortable with, but may not always dominate conversations. Where there's evidence that an intervention reduces morbidity, mortality, incidence, illness, whatever word you put in there in collection of words, that's where the discussions should and must start, prioritizing the evidence-based interventions, both for health systems and community health systems. The program interventions need to be based on the most up-to-date country epidemiologic data. Countries, as you all are sitting in countries and come from countries, know that every country is different, unique in how services are delivered, but also the progress that has been made, whether it be in HIV treatment coverage or next generation nets for malaria, or TB diagnostics and the introduction of new diagnostics. You know where the country program, national programs are at, and that needs to be also the starting point. Then you look at the interventions that map to that epi context. For those where we have lower impact interventions, they need to be reduced and eliminated. There are interventions that might have been used for years that may no longer be fit for purpose or actually don't match the epi or are not needed at the same scale. And the reason why this is so important, as well as the third piece, which is simplifying program delivery and reducing program management costs in all ways possible, is that the partnership needs to create space for the new innovations for disease management to take hold. We're excited by TB diagnostics that are new and sharper and better at their jobs. We're enthusiastic about lenacapavir and its introduction. These take financing, they take money. And in a shrinking fiscal space, in order to allow for some of these new innovations to be brought in and scaled, other things must recede, or we must become ever more efficient. So that simplification of program delivery, removing the complexity, removes management costs and makes things fit for purpose for the future with smaller pots of money. Next, please. I've already mentioned a bit of this. The simplification and the prioritization allows for access to innovations and life-saving products to be brought in at scale. We need to, as a partnership, bring in the introduction of these new innovations faster. We don't collectively have time to introduce things slowly. This is the products, the delivery platforms, and the data systems need to be brought up to speed, need to be used wisely in order to make the introductions of new interventions as fast as possible. The innovations have to be catered to the people that we're serving. And that may seem like an obvious statement, but really looking at when you are introducing a new innovation, where should it be introduced first? Where can it have the most impact? Who are the people and the populations that are most at risk, that are in need, the highest need for the new innovations? This is a form of prioritization, and it may not feel particularly nice or easy, but is necessary. And the third is really supporting sustainable access to these life-saving products. And that is through market shaping both new and existing commodities and the efficient supply chain management. These are incredibly important things about the future. This is sustainable program design. The supply chain management, which so much effort is put into for many, many years, needs to both continue, but the level of efficiency, integration, thinking in with the long country lens about in 5 years, what does this need to look like? And what are the steps in GC8 that would support getting to that longer term vision? The Global Fund Secretariat, with different partners, are really committed to continuing to help shape the markets so that best pricing is available to countries, whether they use their domestic dollars or whether countries are using donor financing. And I'll come back to that in a moment. Next, please. So the fourth is all about integration. I just want to acknowledge the incredible work that I know and are hearing more about that is going on in integration already. Countries are leading by example, moving forward to say, how should and must we integrate HIV, TB, and malaria services and systems and health systems, multiplexing of health systems to bring down costs and to make sure that there's really a sustainable approach for future. Next, please. So integration of service delivery. This is just not about integrating HIV, TB, and malaria. This is really about integrating the three diseases into the platform that a country has determined it sees its future delivery for these three diseases. For many countries, what we understand and hear and see, it's that a focus on primary healthcare, bolstering primary healthcare, making space in primary healthcare for integrating HIV, TB, and malaria services. In some places, this has been the natural way business has been done, which is great, and more of that needs to continue. In other places, that is not the case. Programs might be, and services may be very verticalized at this point. So really taking the opportunity of GC8 to look at a platform for how to integrate these services. The same is around health systems. Siloed approaches to disease diagnostics or sample delivery, surveillance, human resources, community health workers is not a sustainable approach going forward. That costs more money, not less, is more complex in terms of management and oversight. Both pieces are important discussions in integration. Next, please. The fifth, community systems and financing. Next slide, please. We're grateful to, I say we, that means everyone, is grateful to communities worldwide that are global and local and that have really pushed to say, if you want to see good health outcomes, you must involve community. It has been the backbone of the three disease response in many ways. We've seen great partnerships with government and the integration in some cases already of community systems. Community health workers is an agenda that has grown over time and been embraced by national governments, integrated into their cadres of healthcare workers. These are all really positive. And yet, we bring this forward as a key shift because it's vulnerable. Many community systems for health are financed external to government and domestic financing. They may collaborate with the formal healthcare system, but they are often financed externally and financed through donor dollars. This makes them vulnerable in the long term. For countries that are transitioning, this is a particular note, and we'll come back to that probably in the Q&A. But for the shifts, there are four areas of focus. One is for countries that are lower income, very high disease burden or challenging operating environments. It's the readiness of how to integrate community services that may be adjacent to the former healthcare service delivery system into the government healthcare delivery system, doing that carefully, respectfully, being aware of key populations and specific needs. Not trying to say this is easy. It needs to be done with great care. The second, for countries that are in upper middle income or upper lower middle income with high absolute disease burden, the focus should be, as we're recommending, on strengthening integrated community systems and fast-tracking social contracting. How to take the time to see how government systems for financing can be used for social contracting, directly financing of community systems, and strengthening the integration pathways. And then on the next one, on resilience, this is in countries that are upper middle income or lower middle income, but with absolute lower disease burden. And here the focus we're recommending be on social contracting, to have viable pathways for sustainable financing and tailor to the context. Lastly, we realize and have heard and know that there are contexts in which key populations are extremely vulnerable. For this, we're looking at a shift that includes protection. So how to have a very tailored approach to those very specific country contexts where protection is needed. And that's far more differentiated and individualized by country. Next, please. So the last one I'll speak to is really about optimizing domestic resources and effective co-financing. Next, please. Domestic resources are an important part of, incredibly, the pillar of sustainability, and particularly for those countries that will move into transition in GC 8 or 9, the domestic co-financing is incredibly important. How is it optimized? First off, the co-financing of the Global Fund grant, as I already mentioned in my opening comments, needs to be highly differentiated, and there needs to be a quality behind the work. What is funded and how much? It's just not the how much, it's what is funded. The second is how to ensure that the global public good of market shaping is shared with countries using their domestic resources. So again, this is incredibly important for countries that are cycling off of donor of Global Fund resources. How can those countries have access to quality assured, competitively priced products? There is a work stream now happening on it's a bit of a mouthful, non-grant finance procurement through a pooled procurement platform, WAMBO. So this means for countries being able to use at scale, if they should desire, domestic dollars and using the WAMBO platform directly to make procurements. And the third grouping of how to optimize domestic resources is really the financial systems and models. This has been done in smaller ways with some countries, but we really need to see an increase in blended financing opportunities, debt to health opportunities. And then lastly, the public financial management support for the capacity and strengthening and the integrity of public financial management systems is incredibly important to sustaining health and the three diseases in the long term. Next, please. So what are the next steps? Next, please. So this grant cycle and the shifts that have been laid out, what does this look like? In-country disease programs are really on track in many ways for having sustainable programming and planning good transitions. If countries are in a GC 8 or 9 situation where this will be the last allocation, how those disease programs, what do they need to look like in the future? Where do they land? How are they integrated? How are they financed? Is incredibly important to dominate the conversation. How can the grant life cycle for GC8 enable really looking at sustainable program design and effective transition pathways? Certainly it starts through the country dialogue and what results from that in the funding request. There are a number of ways in which the Secretariat and the technical partners are ready to support in that engagement and give opportunities for flexibility and creativity, because that's what it will take. This will be very individualized, and the country teams are, for the Global Fund, are the front-facing and are ready and already walking with you on how we can support you in the country discussions and dialogue that come, and ultimately the funding request. The funding, the GC shifts will also be looked at through the lens of review. So the TRP, as they review the different funding requests, they will be looking for the shifts. They will be looking to see how they've been manifested described in the budgets. And the same will happen through the Grants Approval Committee. We also, at the Secretariat, are working on how to monitor the shifts. This is something that we should all be keenly interested in. It's not very useful to put out an agenda or supportive processes and have no way to monitor to see how we're moving through this. And what's at stake is that if we are not collectively together and collectively successful, then we will see quality drop. We may see programs not move into successful transitions, and we may see no room for innovation. So we must be together and committed to looking at GC8 differently, through the lens of sustainability, through the lens of effective and well-planned transition pathways, as well as through the lens of very rigorous prioritization. And I think I'm going to end there, Marcella. I think that's the last slide. No, sorry, there's 2 of 2. I think I've already spoken to some of this, but what are the practical ways to start? Obviously, they're to map out the key milestones on the transition timeline, where countries that are seeing GC8 as their final allocation. Really important. Make a plan for key investments to be transferred to domestic budgets. This is all countries. This is not restricted to those countries transitioning off in GC8 or 9. We should and need to see collectively domestic budgets for health both grow and be targeted in what they fund. Very hard to do this, but there need to be interventions that are deprioritized. And these are difficult discussions in country. They need to be based on EPI and program coverage and plans to simplify what can be deprioritized. If you start with prioritization, it is very difficult. You need to bring in deprioritization at the same time and have those honest discussions. Looking at where integration makes sense. Integration is not a thing, it's a process, and the process allows for improved outcomes, patient-centered care, and in long-term longevity of the 3 disease programs. Then look very carefully at community health and community health systems and private health systems as well, and how to integrate those into the national healthcare delivery program. Where does it make sense? Where can you start, or where can you continue to push and scale? And then lastly, the social contracting. I think you'll hear this often as the Global Fund Partnership speaks about the critical functionality of community health systems and the incredible importance of securing long-term financing for community health systems. Next, please. Q&A. So I'm going to stop there. Thank you very much for your time.
Julie.
Thank you for joining, and Marcella, back to you.
Okay, thanks a lot, Julia. We are going to start with Q&A. We've been receiving your questions. If we go, Matt, to the next slide. We have quite a few questions on the components referred to in slide 9. I'm going to read them for interpretation. We also have our head of health financing with us, so I'm just going to read them, and Matt, then I'm going to pass on to you. Please kindly share a document which outlines these components and countries. Just to let you know that the information about transition timelines is included in the allocation letters that the Global Fund sent. These allocation letters have been shared with applicants, which are often CCMs, and have received an allocation for GC8. The next similar question is, how can we know which countries are final allocation for GC8 and GC9? The decision about transition timelines has not been made by country, they have been made by disease component. In some cases, countries may have a final GC8 allocation for one component and not another. There are also countries that have GC8 timelines for one component and GC9 timelines for another. The information about transition timelines for each component will likely be shared by the Global Fund once all allocation letters have been shared. The Global Fund has prioritized speaking first with countries directly about transition timelines before sharing them in other forums. The next question is in French, but Butena wants to know what's the criteria used to choose the 63 components that we talked about in slide 9 as well for transition of GC8, and how was the choice made to have the transition in 4 to 5 years. Matt, rather than responding this one, I'll let you summarize the rest of the responses if you want on this one as well, please. Thank you.
I think you've covered it, Marcela. All of the information around the transition timelines was shared directly in the allocation letters so that we could start the conversation directly with countries on how we do the things that Julia laid out in the slides. So I think you've covered all of the content for these questions.
Okay, thank you, Matt. We'll call you in as there are other questions on transition. Can we go to the next slide? Julia, so we have several questions from David Bryden. How is the Global Fund using its engagement with the US MOU process to encourage civil society participation in negotiations and planning? How should the Global Fund planning take into account specific reductions in funding for HIV, TB, and malaria that are included in the US MOU agreements? And related to co-financing, how should planning take into account co-financing commitments already made to other donors, such as the US or others? And in some cases, these commitments are extremely ambitious. And then we have another question that it was related to your presentation on the presentation part of the prioritization, reduce management costs, and what does that mean? An example will help us understand.
Great, thank you, Marcela. And Matt, I'm going to call on you for the third part of David's question. So thank you very much. So for the US MOU process and civil society, so I want to speak just more broadly about the MOU process, and that the US has proactively engaged the Global Fund partnership and the Secretariat from the beginning. And we're appreciative of that because we are connected in many ways at the country level. And so we have had insights into how the MOU process and dialogue has evolved in several of the countries, at least on the continent of Africa. We have been kept abreast of its progress and what's included in the MOUs. And I'll tell you how that feeds into, in some ways, into the second question. We have also been clear from our side that the Global Fund places a high priority on the engagement of civil society. And you've heard me speak about this through the shifts. And one of the key shifts is all about community systems where civil society and communities dominate, obviously. And so the US is aware that for our planning purposes, civil society will remain engaged. And we've also spoken to them directly in our back and forth about how important it is and the voice that that brings. Can we do more than raise the profile? No, in that we cannot tell the US how they need to approach the MOU process, which varies from country to country. But we have highlighted why we think it's important and why we will continue to prioritize and ensure that participation is there and meaningful. Specific reductions in the 3Ds funding and the MOU agreements. I'm going to speak then to the allocation model and the approach to which the allocation model is both a formula and it has we do adjustments after the formula. The formula is very much based on disease burden and economic status of a country. Then what comes after that is what we refer to as qualitative adjustments, but in normal language is to look at the context of a country by country, literally country by country, to see whether the formula derived amount is an appropriate one or whether adjustments need to be made. And during that process, we discuss external financing. Obviously, the US has been the largest external financer for the 3 diseases, and so the changes in their financing have an impact at country level. So it has been incorporated as one of the metrics in the qualitative adjustments to the allocation formula and ultimately the allocation that's provided. I want to say a caveat here is that the reductions in US funding in the 3 diseases are very significant and grow in their significance over the coming years. And the Global Fund does not have a capacity, i.e. a financial capacity to gap fill. It simply does not. And Peter Sands has been very clear, both in when he speaks to this and to the board. This is why the prioritization is incredibly important and why it will feel very difficult, I think, in the country discussions as we see prioritization taking on a different level of meaning and importance. I'm going to speak to the management costs and then pass to you, Matt. The management costs as a few examples. There are a lot of things that go into management and oversight, including site supervision. If you do that country or disease by disease program, it's inefficient. How do you reduce that as you do it together? How do you streamlining it reduces the cost even more? Time spent, personnel hours. In addition, it may be important to look at who is providing, I dare say, how many implementers are used, and is that efficient or not? Is there duplication or not? These will be discussions that will have to happen. Looking at unit costs for delivering things and ensuring that they are stripped down to the most essential. This really also feeds into the simplification of service delivery as well. So some of these shifts are not isolated from one another, and they build off of each other. Matt, over to you.
Thanks, Julia, and thanks, David, for the good question. David, as the question says, there are a number of different organizations who work closely with countries to make co-financing commitments, including the US and others. In general, what the Global Fund is really pushing for GC8 is for us to work really closely with country stakeholders to see how these co-financing commitments can come together. In some specific cases, such as the case of Gavi, we have formal guidance around how commitments made toward Gavi malaria vaccines interact with the Global Fund's co-financing requirements. In other places, such as with the new commitments being made in the context of discussions with the US, this is more of a new conversation, and we don't have perfect published guidance yet. In general, however, what we always like to push is that we want to see these commitments be complementary, as aligned as possible, mutually reinforcing, and realistic in the context of a country's fiscal space. So as we move into GC8, we'll certainly be thinking about how we can make sure that the co-financing commitments made to the Global Fund are strong and strategic and well-targeted, but also how they fit with the other commitments that have already been made and how they can mutually reinforce. We certainly want that to be a country-by-country discussion. And I think it's really important in the context of the funding request process to start those conversations as early as possible. We have seen challenges in the past of getting really good commitments finalized by the time our grants are approved, and that's something we want to change in GC8. So the earlier we can prioritize not only what we're thinking about doing with Global Fund grant financing, but what countries are committing to themselves and what costs they're picking up, the more we're going to be able to have a really good sense of that balance as we get to finalize the grants. I'll pause there.
Thanks, Matt. We're moving to the next slide. Julia, we're trying to move up the questions that are specific to the shifts, and we will still try to respond to all of the questions that participants have. For now, we have fast tracking social contracting systems means what? An example will help us understand. Given the strategic weight of these shifts while considering the diverse context of countries, how directive will the Global Fund be in the designs of the GC8 grants, TRP reviews, but also implementation arrangements and risk management? Domestic co-financing means the country will have to input finance, and regarding pool procurement, wouldn't it be more sustainable to invest in national or regional PPMs rather than WAMBO, as the former shall exist even after Global Fund support? Julia, I let you see if you want to respond to any of these questions or pass to any of our panelists available, and then we move to the next ones. Thank you.
Sure, thank you. And I think A is catered to, I think, or sorry, 6. For Brendan's comments and number 7, I appreciate this question being asked because it allows me to make a statement that the Global Fund is not fundamentally changing its approach on how it interacts with countries in terms of the country dialogue and the funding requests. This is country ownership remains a strong pillar, an important pillar of the Global Fund model. And so how directive will the Global Fund be in the design of the GC8 grants? I don't want to say that we aren't making recommendations. We are, but we will not be directing countries to do X, Y, and Z. What we hope is that the shifts will be taken into the country dialogue, and the country teams and others will do that they will be well considered and how they could be and should be applied. But we hope that they are actually helpful to countries as you work through the very difficult fiscal space that most countries find themselves in, and that give flexibility to do things differently. So I would say we're recommending. There might be strong recommendations, and we're not going to back away from that. But there will not be direction given, but the implementation arrangements, those sit with the CCM, determining the PRs and consequently the subs as well. For the TRP reviews, the TRP has already been part of the conversation around the shifts. They will continue to get more and more comfortable with them. They will use the shifts and the allocation aims and the Secretariat briefing notes per country to understand the context and know where to look and what to look for. So if the shifts are not reflected at all, do I think that might be an issue in the review? Yes. But it is not, but they need to be taken and applied to the country context. So pooled procurement, I can answer this, but do we have anyone from our supply team that would like to, is Marasi happen to be here, or, and if not, then I'll take it. No?
I think Marasi is not, Julia, but we can also, it's anonymous, unfortunately, but otherwise we could send a response.
No, it's okay. Pool procurement, to invest in the national regional. It's also a great question. Thank you for raising. The regional, national is different. You have to have very big volumes. And most countries around the world are not big enough to get that kind of volume for pricing. Regional, very much so. And we are working as part of the Next Gen Market Shaping Initiative on how to work with regional entities in a more concerted way around their pool procurement platforms. And so it is not that we are working to make WAMBO an exclusive, not at all. So I'm really glad that you raised that, because I should have actually spoken to that. And domestic co-financing. Matt, do you want to come back in on that?
Sure. When Julia was talking about the strategic shift around growing and optimizing resources, one of the things that she referred to is the how we use co-financing to achieve what we need to achieve on the domestic financing front. So what that is referring to is that in GC8, as in previous cycles, countries will need to be making co-financing commitments in order to access the full Global Fund allocation and the grants. Those commitments differ depending on country. In lower income countries and lower middle income countries, the commitments are focused on both health spending overall, as well as specific commitments to specific things. In higher income context and in context related to transition, what we're really focusing on in GC8 is specific commitments to specific programmatic interventions, including those remaining relevant grant costs, which we know have to ultimately be put into country budgets and financed sustainably. And so that's what domestic co-financing is referring to in that case.
Marcella, just before you flip on, I realize in looking at number 9, just to clarify that the non-grant finance procurement is about countries being able to utilize WAMBO even if they are not a recipient of Global Fund funds. So it really is about an offer and creating a pathway for quality and best pricing commodities. Thanks. Back to you.
Thank you, Julia. We can move to the next slide. So alignment and transfer of core program costs to country budget is not realistic considering the fiscal space at the country level. The regular overhead and program costs have not always been met. Adding a new core program cost will be difficult in some contexts. So this is a comment, not a question. Thank you, Julia, for the excellent presentation. You mentioned about integration. How will the Global Fund monitor to ensure malaria, TB, and HIV and services are accessible to migrants, refugees, and indigenous populations who are in most countries not part of the national health insurance? Okay, so how is the specific support from the Global Fund in countries to elaborate programs on transition, considering transitions is not going to be ready for the elaboration of GC8. I would like to have clear information on social contracting as well on transition and sustainability, and how could we transfer to domestic financing? Sorry.
So Marcella, I think Matt, please ask so we can have a change in voice. For 13 and 14, Vujiseka and Anna are with us. Could one of you please take 13 and 14?
Sure, no problem. Thank you for there's lots of interest in social contracting, so thank you. First, I just want to reiterate upfront, we don't see social contracting as the panacea to solving all our problems around ensuring that there's continuation of funding domestically for particularly community-based organizations, services that are so critical to the work that we do in country to reach those that need them the most. But what we're trying to do through GC8 and this shift is where there are opportunities already, and there is already discussions happening in country about how social contracting could work, or how we could, or where there's really a strong need for us to accelerate the work of transition in that. Work together with government partners and communities to see how to do it best. In some places, there's just needs a bit of extra acceleration to get over some of the policy or legislative bottlenecks. In other places, we need to work really closely with community-led organizations on developing capacity to be able to be contracted by government. And in other places, it's just not going to work at all. I think there's a question later down related to KP-led organizations working in highly criminalized contexts. We will have these discussions in country and other options and think through. And that was particularly as highlighted in Julia's slide, where we have thinking around protection mechanisms that will evolve throughout the journey of GC8. But we have a few countries that have been selected as eligible for matching funds for social contracting, where we will be working to really accelerate and we'll see how this goes. We're also not the first to support this, but for other countries that is not part of that, you are also able to use your grant allocation money. There are modules that can be invested in the modular framework that are explicit around the social contracting, and particularly for civil society organizations, and thinking at it as part and parcel of how you are developing and building a health system that's fit for purpose in country for key populations. Thank you.
Thanks, Anna. And then, Marcella, if Shun or member of the integration team would like to take 11. If not, I will speak to it, but.
Sure. This is Shun. Thank you for the question. It's a tough one because the integration, as you probably indicated, is not the panacea, has risks, particularly around the key and vulnerable population, depending on how the primary healthcare covers such population. So I think country by country, we need to work with the country about specifying the key risks based on what country wants to integrate and what country wants to keep, and then have a particular plan to address some of the particular population that may be missed through the primary healthcare service delivery mechanism, depending on the country's situation. So really, we need to work together with the country by country on those risks, and then try to find a way to monitor the population. Thank you.
Thank you, Shun. And then Matt, can you come in on Ibrahim's question for 10? And then 12, and I think you could probably do both.
Sure, happy to. Thank you, Ibrahim, for the question. So first and foremost, when we set the co-financing requirements at the Global Fund, we work to take into account the economic situation and income level of the country. And in those places where there is really challenging fiscal space concerns and considerations, we're quite cautious about increasing the amount of co-financing requirements above the standard amounts that are in the Global Fund board-approved policies. So it's absolutely an important consideration. There are going to be certain places where the fiscal space considerations are really challenging. And in those cases, the way we want to think about co-financing is two ways. One, using co-financing to try to have the right conversations with countries and governments about increasing the overall resource envelope for health. We know that in many places, the percentage of government expenditure spent on the health sector is insufficient to finance the national responses and finance the health system. And so really using co-financing as a way to have that conversation about increasing resources for the health sector is quite important. And in addition, where there are those very specific fiscal space challenges, being really realistic about what countries can commit to, the specificity of what they're committing to is the type of conversation we want to see at the country level. That said, we do need to use country GC8 to be looking at opportunities to increase country investments in specific programmatic interventions, because we still see many dependencies across the portfolio on external financing. And in a pathway to self-reliance, to increase financial sustainability, those are the things that we want to try to address in GC8. On the question number 12 around transition, I'm not sure we have a specific solution on how to manage the transition process. A lot of our learning from countries, from our partners about transition historically has been that countries face very diverse transition challenges. And there are no single or silver bullet solutions. What we really need to do is be identifying those challenges that are specific to a country context, given the epidemiological situation, the way the health system is set up, the dependencies on specific interventions for the Global Fund, and then using everything Julia talked about, grant design, the country dialogue process, our co-financing commitments to try to address those specific things. As Julia mentioned, even countries in the GC8 cohort will have 4 to 5 years to manage this transition process. And we wanted to communicate these timelines now so that we could start as early as possible working with countries to address whatever pathway they need to use in order to transition as well as possible.
Okay, Marcela.
Thanks, Julia. Yes, next slide, please. So we have a question on digital health. It looks like data infrastructure will be even more important for up-to-date epidemiological data for prioritization and supply chain management. Will there be extra support like the SI Digital Health Accelerator in GC8? Could you clarify the timing of the integration and transition of service delivery and health systems? Is this expected to be planned in detail at the funding request stage and implementing during the grant with a deadline at the end of GC8? Can the detailed integration and transition planning take place during GC8 itself, together with its implementation? How to guarantee that the interventions for communities are integrated within the interventions of the health system, public health system, without canceling the potential contribution of the community organizations. And by when will all the countries receive letters? And the answer is there, all allocation letters will be sent out by March 20. Thank you.
Okay, so I think Marika is with us and to respond to 15.
Or Sean, I think, Julia.
Thank you, Julia. And I can be very brief. There is some matching funds available for digital health for a small subset of countries, and those countries that are eligible for those additional funding to support the digital health improvement and development, they have received that news in their allocation letter.
Great, thank you. And then, Anna, do you want to come back in on 17?
Could someone repeat that question for me?
Sure, Marcela can.
Yes, sorry. It says how to guarantee that community interventions are integrated within interventions of the health system without canceling the potential contribution of the community organizations.
Thank you. So that very much remains part and parcel and core of what we do and fund here at the Global Fund. So communities remain at the center. And in thinking about, and of course, there's challenges now at the moment when thinking about integration, but prioritizing where it makes sense to integrate community-based services with primary healthcare services, but also where it's not possible, that we will still fund and we still will support, specifically for key population programming, community-led and community-based organization service delivery, prevention, keeping commitments that were outlined, for example, with the UNAIDS targets of ensuring that 80% of HIV prevention services for key population and women should be delivered by community, key populations and women-led organizations. So all of that remains part and parcel of what we expect to see coming through funding requests and what we support investing in. So I hope that provides some reassurance to Hamidou, who asked that question. Thank you.
Thanks, Anna. And The social contracting is about financing of community in a way that is sustainable. And I hope that people are sensing that while social contracting isn't new, and some countries have done it quite successfully, it's not at the scale or doesn't get the same prominent view across many countries where it really does need to be and should be considered as part of the sustainability package. So be assured that this remains a priority. And then on question 16, if this is referring to countries that GC8 is the final allocation, then it is super important that as much planning happens in the course of 2026, if a standard timeline for grant start should be the start of 2027. So if a country is on that pathway, it is really important to make the most of the planning period to get clear on how integration and that transition of service delivery and health systems can and should happen in the course of GC8. However, I'm not being silly to think that this is an easy discussion or a quick one. I think it is important for all countries where integration is being discussed, whether GC8 transitioning or not, that some core objectives and milestones are laid out in the planning, so it's clear what the country is driving towards and on what timeline, even if the details of how that gets implemented need to be worked out through the course of GC8 delivery and implementation. Countries that are not on a transition pathway will have more luxury in doing that combination. But during the planning phase, coming to agreement as a collective in country about what integration looks like, what's being integrated into what is not being integrated, and what kind of timeline you're on and what you expect to see over the course of that timeline is important to put those markers down during the planning period, if not all the complete details. Thank you.
Okay, thank you. Okay, so how will the Global Fund ensure domestic resource and co-financing allocation also covers community-led and services and community system strengthening? Can countries include other health components as part of integration rather than HIV, TB, and malaria? Could you explain more on the integration of health systems? How does the Global Fund expect HIV services for criminalized key populations to continue with government funding? Social contracting will exclude key population-led organizations. In such context, would the Global Fund continue to fund these programs? And will the Global Fund also be supporting countries to develop their integration frameworks, especially with regards to metrics of integration performance and outcomes? How far is the Global Fund willing to extend to incentivize countries to positive intentions, promises at least, with regards to sustaining support for key populations in their transitions and sustainability plans?
Okay, thank you. So I think on this sort of suite of questions, Shun, and why don't you start us off? And I think 21 and probably even to some degree, no, 21. Let's start there. Thanks.
Thank you. Yeah, I'll cover 20 and then probably 21 and 23. Thank you. So on question 20, thank you for that. What we are aiming to support is the integration of HIV, TB, malaria, but through the primary healthcare or other platform the country chooses to support. So it is an integrated service delivery platform that includes maternal and child health and other health services. So through that integrated services lens, we'll be able to support other part of the health concerns. And we have been already doing it, for example, through the supporting the Cleveland community health workers to deliver integrated services. So that's possible. And on the question 22, so I just talked about the service delivery integration, but there are many health systems components, for example, health workforce or laboratory system that has been managed more vertical way that can benefit from sustainability and efficiency point of view, and also potentially the quality in the long term point of view through the integration. So in the upcoming the prioritization document, we will have more messaging around the integration of workforce, integration of lab systems, sample transport, and data systems, etc. That we are very much keen to support if country prioritizes. And then the last point on the 23, so we are really aiming to support countries to have its own integration framework or integration plan. And we are, for example, carrying out in-country integration workshop where the country stakeholders define integration priorities and then link it to the funding request. And that, of course, links with the metrics that the country wants to use about measuring the progress of integration and some performance outcomes. So our team and the country team is very much keen to really support throughout that planning process, depending on where the countries are. And then also there are some matching fund for integrated service delivery, as well as the social contracting that Julia and Anna mentioned, to support integrated services or incentivize integrated services, and also sustaining the support through the community-based and community-led organization. Thank you.
Thank you very much, Shun. Anna, do you want to come back in on the key population specific parts of maybe 23 and 22? You've already touched on things. I don't know if you want to add anything more.
Sure. I think just to reiterate that we really do recognize that criminalization and legal barriers mean social contracting is not a universal solution. And where government channels are not appropriate or safe, that we still and we continue to invest in KP-led programs directly through civil society, principal recipients or sub-recipients, while also investing in the enabling environment for KP-led service delivery to be protected and sustained. As we journey through the transition process, I think this is going to be one of the most critical questions that we need to work collectively on with all partners and stakeholders. And it's not an easy one to answer, but for GC8, we continue to invest and support this work. I think that's the key message here. Thanks, Julia.
Thank you, Anna. And then quickly, Matt, did you want to, at 19, I know this is part of the differentiated work that you've been doing and leading.
Yeah, as you mentioned, Julia, we need to see differentiated co-financing commitments in GC8 that really look at country context and the specific financial sustainability and transition challenges. And certainly using co-financing to incentivize commitments toward community-led services is a key part of that. Earlier in the presentation, we talked about matching funds, and there are matching funds in some of the countries. But matching funds is only one solution, and it's only available for certain countries. This really needs to be prioritized across all countries where we see continued reliance on external financing for community systems and community-led services, which we know are super critical to programmatic impact. And so leveraging co-financing is certainly one piece. The other thing that I would say is bringing in the discussions around community-led services in broader conversations about transition and financial sustainability in engagement with ministries of finance and ministries of health is going to be really critical so we can see shifts in financing in GC8 and beyond.
Thank you. Marcela, back to you.
Yes, thanks, Julia. So health ministries and CSOs, in order to reduce cost, has to prove the cost reduction or managed activities, it means that the PR is part of the reduction. I guess they're asking about the management costs and if, PRs need to also have cost reductions. Access to innovations and life-saving products are under Next Gen and market shaping. Can the global funds facilitate procurement of quality assured medicines from local manufacturers, even without WHO pre-qualification, as long as the country regulatory body certifies that such products are good for human consumption? I don't know if we have Marasi in the end.
Marasi is with us now, yeah.
Okay. Please make provisions to directly engage civil societies and affected communities in TV programs in the countries. This is more a comment. And then again, on social contracting, there is no clear guidance on how to operationalize this, and Global Fund can facilitate a holistic conversation with other GHIs to get the best of these for CSS and health financing.
Okay, Marasi, we'll have a new voice. If you're with us, do you want to take us off on Ibrahim's question 25?
And good afternoon, good evening, everyone, depending on where you are. My name is Marasi Mwenche, and I lead supply chain for the Global Fund, and I'll be responding on behalf of some of my colleagues on this point. And so, Taji, I think it's an excellent point that you raise. From a Global Fund policy standpoint, patient safety, product quality are non-negotiable for us, and that's regardless whether it is an innovative new product like lenacapavir, whether that's produced locally or essential. Now, we have quality assurance policies for our pharma products that set very clear pathways in terms of how medicines are procured using Global Fund funds. And there's 4 requirements that one of which must be met. First and foremost is a WHO pre-qualification. Another option is authorization by an SRA, that's a stringent regulatory authority. Thirdly is whether it's authorized by a WHO listed authority, WLA. And then fourthly is whether it's recommended for limited time use by a Global Fund ERP. So to your question, certification only by an NRA, in the case I think you may be referring to NAFDAC in Nigeria, alone is not sufficient. Now, unless that NRA is also recognized as a WHO listed authority. Hope that helps answer the question. Over.
Thanks, Marasi. I'm going to speak directly to Juan Carlos, your first question. Everyone needs to be involved in cost reduction. Secretariat is everyone. We have less money all around, and the weight of that responsibility does not fall on one part of the partnership. It's the entirety to make the money go the farthest. So thank you for your question. And on 26, we, of course, would want civil society to remain engaged in TB programs, incredibly important on the ground. And then the last one on social contracting, I think we've had a fair bit of discussion on this. The Secretariat and through additional partners are and we have additional funds for this to help provide a real push on social contracting. It's different in different countries, in different contexts, particularly if you start to use government systems for social contracting. So we do want and intend to walk with countries, not that we just say, please do it and try and figure it out. And so thank you for placing that back on us, and we will rise to the challenge. Thank you. I think we can move to the next.
Thanks, Julia. So it seems that countries that have Euro grants had higher reductions than those that have US grants. Can you speak to how foreign currency fluctuations are captured by the allocation formula? Is the funding accessible to all countries with the desired structures, and are there other legal parameters that may restrict funding? And could you please comment on the protection of services for key populations and give examples of how these key populations protections will be ensured in the funding requests?
Okay, I'm going to, for 30, I know, Anna, you've been doing a lot of talking. Other colleagues may be on the line. Michelle, Vuyiseka, or Anna, please take it. And then we'll move to the other two, which are financial.
Happy to go again. Not sure who else is there. But absolutely, we require all funding requests to demonstrate how key population services will be protected, including in restrictive legal environments. And this is assessed also through CCM eligibility requirements and ensuring that communities have participated in the design of the funding request through the Communities Annex, which captures key population community priorities independently of government sign-off. And for example, in country where sex work is criminalised, a funding request would be expected to show that sex worker-led organisations are meaningfully engaged in the design of services, and that there is funding flowing through civil society principal recipients and sub-recipients where needed. And the program design protects the safety and confidentiality of service users. For GC8, we're taking a much increasing level of concern of ensuring safety and security, and that needs to be built into grant funding requests for key population groups. And where identified gaps in KP protection are during the review, that will still be highlighted through TRP reviews and through iterations and mechanisms. So again, it's a core part of what we fund to end the epidemics, and we will be looking closely to ensure that those priorities are included in funding requests.
Thanks, Anna. Maria, are you with us, and could you speak to 29? No. Okay. I'm going to switch to Hannah, then we'll come back to 29. I would like if a grant management colleague could speak to it. Otherwise, I will. But on the allocation model.
Hello, everybody. So as we previously discussed, allocations are calculated predominantly based on country economic capacity and disease burden. They are calculated, all of them, in US dollars, and then as necessary converted from US dollars to euros, depending on the denomination of the grant. There is no association between any foreign currency fluctuations and the calculation of the Global Fund's allocations. And actually, just to add, there are fluctuations each cycle that affect the conversions each way. So that's the normal part of our cycle.
Thank you, Hannah. We have an excellent finance team here at the Secretariat that works tirelessly to make the money go the farthest in spite of currency fluctuations, which there are many right now. Do we have any grant management colleagues that would like to take 29? Okay. And if not, I think the question, sorry?
Sorry, Julia, I was going to say we can come back to that one if we have a grant management colleague joining and we can go to the next questions, or?
Yeah, I just want to make sure I fully understand funding accessible to all countries with desired structures, and there are other legal parameters that may restrict funding. If a country receives an allocation, the use of that allocation and the principal recipients and subrecipients are decided within the CCM. There are parameters that the CCM must adhere to in their selection of their PRs and SRs. I think if it's about the country itself, legal parameters, their countries are eligible for Global Fund funding, and there's an eligibility policy. It is on our website, and then from there, countries will receive an allocation. Not all countries eligible receive an allocation, but the vast majority do. And so eligibility, there are parameters in the eligibility as well. So there are parameters all the way along. You are either eligible, then you are eligible and get an allocation. And then the use of that allocation, who exercises the use of it, is under the remit of the CCM in PR and PR selection, and it goes from there. So I think we can move to the next, and hopefully I've covered.
Could you further clarify from your response to David Bryden's questions? Are countries allowed to count domestic funding they're putting forward to meet USG MOU's co-financing commitments? Also allowed to count towards the Global Fund's co-financing requirements? Thank you for this helpful summary. The use of domestic funds to procure health products via WAMBO platform is interesting. The gains from the PPM marketing shaping could be extended to health products that are domestically funded. How does the Global Fund view the balance between extending these gains and the broader objective of countries strengthening their own capacities and systems for health procurement and also local manufacturing? When can we expect core technical guidance documents for GCA to be published besides the funding request form and annexes? Apologies if I missed a response. You have highlighted that Global Fund will assist smooth transition to countries. Does this mean that some countries' allocation will end in GC8 or GC9? What if some countries will not receive transition as planned?
34 is a hard one. Let me first, so Matt, you haven't spoken in a bit, and I'm going to call on Marasi if you're still available on 32, and I'll take 33. So Matt.
Yeah, so first of all, thank you for the follow-up on question 31. In general, commitments, the way that the Global Fund has always approached this is that commitments made to one entity don't count as co-financing commitments to the Global Fund. And the reason that we've approached it that way is that we need to be thinking about co-financing as additional and additive. So for example, in the way that we approach this with Gavi in malaria is that co-financing commitments made to Gavi for new malaria vaccines do not count as Global Fund co-financing. And that's something we've formally published. The new commitments being made in the context of the USG MOUs are very new. And so while that general principle is the way that we approach this, we also look at this on a case-by-case basis. It also depends on the type of commitment. So in some places, the Global Fund makes commitments with countries on overall increases in health spending. And in some of the USG MOUs, there are also commitments to increases in overall health spending. And in those cases, there's no concerns about double counting or those commitments working together because it's what we want to see overall for investments in the health system. It's a bit more challenging when we're talking about specific commitments to specific things. And so to respond, the general principle is that commitments made to one entity do not count as Global Fund co-financing requirements. However, we take this on a case-by-case basis to really make sure that we're doing this in line with country context. So that's how I would answer that for now.
Okay, thank you. Marasi?
Thanks for the question. And I think I'll break this into 3 parts. First and foremost, regarding WAMBO, I think we see the use of domestic funds through WAMBO really as a complement and not a replacement from what countries are doing or replacing country ownership. And what WAMBO.org provides is market shaping benefits of, quality assurance, as I mentioned earlier, price competitiveness, and also supply reliability. Then secondly, I think there was a question regarding capacity strengthening, and that very much remains central to our work, whether it's strengthening national procurement institutions, regulatory systems, or supply chain management for that matter. And we leverage PPM as a platform to which we're able to benchmark and transition rather than create a permanent dependency on it as a procurement platform. And then last but not least, regarding local manufacturing, the way we look at it is that we aim to use our PPM mechanism to provide predictable demand, look at it to pool volumes and also provide targeted investments through which regional manufacturers who meet quality standards are then able to compete sustainably in the market for different health product categories. Over.
Thank you, Marasi. So the 33 and 34. So when can we expect technical guidance to be published? You have not missed us. This remains an important work in progress. The Secretariat reflected on the context of financial constraint and the focus of GC8 being on rigorous prioritization. And we wanted to hold ourselves accountable in the same way as that we are asking for the country dialogue and decision-making to be accountable to rigorous prioritization. And we are looking at those guidance documents and how they can be streamlined, deduplicated, easier to consume, easier to find things, and highly prioritized, with clear links to technical partner like WHO, for instance, guidance which is far more expansive and very and the official. So as an example, so they are coming, and I cannot give you a date, but it won't be long, because we know you need them now that the allocation letters are out. But it really is about giving you a product that we think matches the focus of GC8, and that we've done our hard work in being as useful to you as possible. On 34, this is a very hard question to respond to, because the success of the transition under a mantra of country ownership is with the country. Our responsibility is to do everything we can to make a smoothness and to raise and focus on the barriers, to highlight things that are in the way of a smooth transition. What the Global Fund is not able to do is to ensure and guarantee that everything will transition smoothly or as optimally planned. That is hard. It's hard to say, but I'm just being very honest in the capacity and where our capacity ends. We will do our best to provide the tools to engage in the conversations, to prompt, to advocate, to protect. But ultimately, this is a partnership, and it needs to be seen that way. Thank you. Let's move to the next.
Thank you. Julia, we have 10 minutes left. We're over time. I mean, we have 10 minutes left with the interpreters with us, but let's go maybe through this slide and one more, if that's okay with everyone, and they can stay a bit longer. What do we mean by life-saving commodities and activities? We know all the activities supported under the Global Fund on Life-Saving, how broad that term is. Thank you so much for the great session. My question is, what else can we do differently given the current global health financing? What about integrated primary care? What actions were taken upstream by the Global Fund with the governments of the supported countries to secure their commitment to this transition? Well, I have this one in Portuguese. Como será doravante? Sorry, if I don't know if you have the English channel or the Portuguese
from now on.
How is it going? The financing going to be designated for CCMs of the most vulnerable countries? Noting the vulnerabilities of community health centers and their reliance on external financing, has sustainability been built into the GC8, GC9 cycle? Okay, so I think I'm going to ask Matt on one thing, but I'm going to try and speed through these, not because they're not important. Life-saving commodities and activities. Yes, you are right. It's a very broad term, and everything is life-saving. There are things that if you take away, people get sick quickly or die. So there are things that in the grand scheme of things have to be present, and there are things that allow those life-saving commodities, for instance, to be delivered. There is a package there, so it isn't only just the commodities, it's also activities around that. This is very individualized by disease and by country context, based on what a country offers through its domestic financing or its healthcare system delivery. So it's a very difficult question to respond to, and that's why it has to be discussed at the country level. But I think people quickly know the things that if the Global Fund is paying for something and it stops, then everything stops. And there are things that doesn't apply to. Integration of primary healthcare, yes. For countries that have determined that
primary healthcare is the platform to carry the 3 diseases into the future, or are they already doing so? It does seem like a very appropriate landing spot, and we're following the lead of countries. It looks different in different places, though. 37, I'm going to ask Matt to come in on that one. My Portuguese is 0 to 0, so thank you for the interpretation. CCM financing continues in terms of the support that's provided to allow that mechanism to operate. I will get back to you in writing if there's some significant change. And then noting the vulnerabilities, 39 of the community centers. Yes, that is why you see community health and community systems financing being one of the shifts all by itself, because we do think it's that important. And so it will be a core part, and Matt, of sustainability and the transition discussion. Matt may want to touch on that as well as 37, please.
Yeah, on 37, so the first thing I think I would say is that while, as Julia laid out, while the scale and scope of the transitions in GC8 are larger than they have been, this is not the start of a conversation with countries. The Global Fund has been prioritizing working with countries to prepare for transition, address sustainability challenges for many allocation cycles. And we really have to reinforce that now. In many ways, setting the timelines, we hope, is a way in which we can work with countries much more seriously than we have in the past on this topic. Because it sets out that predictability that many countries have been asking for. Historically, when we've worked to engage with country stakeholders around transition, there's often been challenges because the timelines, the availability of future funding were not incredibly clear. So we're moving into a place where those timelines should help us be able to engage very honestly and very openly with countries about how we need to manage that transition process and the time that we have to do it. And I think in many ways, that is an action in itself, and it's something that we have to leverage as much as possible. I'll pause there, Julia.
Thank you, Matt. Next set, Marcella.
Yes, Julia, thanks. Is there an existing integration model developed by the Global Fund for managing programs across diseases? Additionally, should disease-specific PMUs, program management units, be consolidated into a single integrated PMU to reduce inefficiencies? If so, how should countries address potential resistance from national leadership and program stakeholders during such a transition? How will you guarantee the transparency of the distribution at country level of the regional allocations? We all know that CCM is mainly dominated by the government. Is any direction given to ensure the community's role or funding allocation? There's a response in the slide for that one. And the last one on this slide is, what are the mechanisms in place to engage the government, Ministry of Health, on the way down to the transition to make sure we're not leaving a gap?
Okay, thank you. I'm going to start from the bottom up on 43. The Ministry of Health and Ministry of Finance are the two most dominant parts of government that the Global Fund will and always has worked with. Yes, indeed. What are the mechanisms in place? There are many, but our country teams from the Global Fund Secretariat engage with ministries across governments as a first point of call, and that will absolutely continue and will intensify for those that are in a transition pathway in GC8 in particular. Then I'm going to go back up to 40. Does the Global Fund have an integration model? No, we do not develop those models. It's very much depending on the country. As I've said, I think it's worth of saying again, countries lead on their healthcare delivery, their service delivery, and where the 3 diseases have not been integrated to date and have been more vertical, country leadership in many cases, have said where they think they need to be embedded and integrated. The Global Fund takes its lead from the country decision-making around that, and then and how the grant can be used to support that. Disease-specific PMUs, should they be consolidated? Maybe. It depends on the country and their decision and discussion, but the public financial management system, which a PMU may be part of, depending on the country, we said is part of the GC8 shifts, that though the strength of those systems is incredibly important, because if the program management units are part of that, that's one thing. If they're separate from that, does that distract from long-term sustainability? It depends on the country. But we need to think about the financial oversight that the country has in place and whether it's fit for purpose long-term and can be sustained in long-term. And then 41, I have now seemingly forgotten the question, Marcella, and I cannot read. Can you remind me, please, 41?
Sorry, Julia, yes. How would you guarantee the transparency of the allocation distribution at country level for regional allocation? So I'm not sure if this is a question related to multi-country.
It is. Yeah. Is there anyone from our team that can respond to this multi-country question? I really, in all full honesty, cannot respond appropriately to that. So if not, then we're, please let us fall. It's anonymous, so that makes it hard. Maybe we can ask somebody quickly while we go to the last sheet, I think, and see if we can get a response to 41.
Sure. Also, Julia, to clarify, we have lots of questions that we are not going to have time to respond to today.
Yeah.
What we will do, and we know that there are lots of people waiting for responses, is that we will share the responses to the questions that we couldn't capture today during the session in writing. And we encourage people to also contact country teams or contact us in the email address we're going to put in the chat in case their questions haven't been answered. And you know, we obviously want to give a response to everyone, but we're also running out of time in the session today. But we'll go through this one, Julia, now. So noting the treatment is given to manage these diseases, is the fund able to finance research geared towards a cure? What guidance will the Global Fund provide to support the introduction of innovations like lenacapavir? What are the submission windows for countries having grants ending in 2027? The responses on the slide. Do we anticipate countries to be considered for Global Fund refinancing in future after they would have transitioned out, considering the uncertain geopolitical landscape? If so, what are the mechanisms to be used? There's also a response in the chat. And then the last one is, thank you for this strategic presentation. My question is, how does the Global Fund foresee to reinforce the role of community organizations, notably those that have a strong experience in communities and social mobilization within the conception of implementation of interventions in GC8?
Okay, because I think this is probably the final. So for 44, research geared towards a cure. No, this is not within the lane of the Global Fund. And I'm not sure which cure we're speaking of, but the Global Fund provides financing to countries to provide services, which include systems, can include surveillance. It can include some work that looks and feels more like research, but it's programmatic, operational research, but not hardcore basic science. So I hope that is clear enough. And then in innovations like lenacapavir. So guidance, technical guidance on an innovation will come from WHO as the owner of norms and standards. And so the introduction of lenacapavir and the science behind it and how it should be introduced comes from WHO. WHO is a partner, a technical partner with the Global Fund. The Global Fund works complementary in what countries are suitable for the introduction and how we can support and facilitate its introduction. I'm using lenacapavir because it's here on the screen, and it is a good example of how the partnership of those bringing something to market, the technical guidance behind it, and then the implementation of how it moves in country has also been supported by UNAIDS, for instance. And so the Global Fund has been fully engaged in how countries pick up an innovation and how we can facilitate creating financial space and fiscal space for the innovation. So it really is a partnership, and there's lots of guidance to go around, and that would apply to any of the innovations that come through. And then I'll just end on the community. It's a nice place to end. Because there's been lots of questions on this. I have interacted with some of the most formidable, wonderful community-based and community organizations who have done a lot for the response. I think, again, to underscore, we believe in the full partnership. Government leadership, incredibly important. And community and civil society comes right alongside that. And we have raised and elevated their prominence as a strategic shift on its own because of that. And so it needs to live on in sustainability and in transition. So thank you for that. And I think, Marcella, back to you.
Okay, thank you, Julia. So as I was saying, we're closing the session. We want to thank all the participants for having come today. We will have lots of questions still to go through and answer, but we'll be in touch. Also, you can contact your country teams. We put our email address in the chat if you want to send us additional questions than the ones we got today. And we will post the recording and the presentation in the Global Fund website. We will also share the link with you. And thank you again for all the work and your participation today. Thank you, everyone.
Thank you so much.